This roundtable brings together leading patient group partners representing various tumor types to explore key opportunities for system-level improvements in early-age onset cancer care. Informed by the collective experience of patient group leaders representing diverse patient communities, this session will delve into persistent gaps in care and propose collaborative strategies for a path forward. A central objective involves reflecting on the National Patient Survey findings, which were just presented, and discussing the need for dedicated AYA programs or early age onset cancer clinics across Canada. The roundtable is moderated by Dr. Perry Tudelman, who is an assistant professor and chair in the transdisciplinary mental health program at the University of Calgary. Dr. Tudelman was also the co-lead of Canada's AYA Cancer Priority Setting Project in partnership with IACAN. We're proud to have brought together leaders from some of Canada's top patient groups for this discussion. So welcome back to our very own Filomena Servideo Italiano, President and CEO of CCRAN, Maureen Elliott from Pancreatic Cancer Canada, Austin Zimmer from Prostate Cancer Foundation Canada, Teresa Tieno of My Gut Feeling, the Stomach Cancer Foundation of Canada. Welcome to Brenda Clayton from Cholangiohepatocellular Carcinoma Canada, Danny Taylor from Young Adult Cancer Canada, Bukun Adegbembo of Canadian Breast Cancer Network, and Michelle Wright from Lung Cancer Canada. In recognition of the size and the expertise of this wonderful roundtable, you will notice that this session is just a little bit longer than the other sessions in the agenda, and it's going to run right until our lunch break at noon. So a very warm welcome to my fellow patient organization colleagues, and with that, I'll hand it over to you, Perry.
Good morning or good afternoon, depending on where you're joining from. I'm thrilled to have you join this session today. We have a really exciting lineup for you. In this session, we're going to be reflecting on key insights from CRAN's 2025 National Early Onset Cancer Patient Survey findings, which you would have just heard about in the previous session. To identify critical unmet needs across early onset patient populations and discuss potential pathways towards coordinated advocacy and policy action. Really throughout the session this morning, we're going to make the case for multidisciplinary, age-appropriate AYA and early onset clinics as a scalable model to address care gaps across Canada. And finally, we'll discuss opportunities for national collaboration across patient groups. And that is so, so important for us to be able to move the needle here so that we can strengthen our collective messaging and impact. So really excited to dive into this important conversation today. Before we jump in, I wanted to give a little bit of context about some of the work that we were doing to lay the groundwork for this conversation. So at my research team at the University of Calgary, we are focused on understanding the needs and experiences of adolescents and young adults diagnosed with cancer in Canada, and to really understand the landscape of healthcare services for this population. We recently led an environmental scan of programs across Canada that serve adolescent, young adult, and early onset patients diagnosed with cancer. So over the last 2 years or so, we conducted a national survey with the 16 pediatric oncology cancer centers and 23 tertiary and quaternary care oncology programs across the country to ask them, what are you doing to offer services specifically to AYA and early onset patients? And shockingly, but perhaps not shockingly, only half of the reported centers that we connected with reported offering any sort of specific programming for young people. And this probably doesn't come as a surprise to many folks in the audience or folks on the panel today. And so by any sort of services or programming, I'm referring to any sort of fertility support, mental health support, access to clinical trials specific to the younger population. And within that, within the 50%, there were significant geographic disparities. So services varied across Canada, but unfortunately, what we found is that there were limited to no services available across Atlantic Canada or Saskatchewan, which is really concerning and problematic from an equity-informed perspective. The majority of programs that are available right now are funded through philanthropic donations. Again, amazing to see the support of the community, but we're lacking sustainability and accountability in terms of being able to support young patients. So this conversation today that we're having is going to be essential to see how we can scale up the supports and services that we're offering to young patients that are so vitally needed. So with that background and introduction, I will get the panel started. So the way that our panel is going to work today are there are various questions that are going to be directed to various members of the panel, and we'll end off with a Q&A from the audience. So the first question that is going to be addressed by a few of the panel members today is this. In your respective patient population, what unmet needs are most prominent in the early onset cancer population? Do you feel that CRAN's survey findings align with what you hear from patients? So big question. And to start things off, I am going to ask Austin to share a little bit about the needs of those in the prostate cancer community.
Yeah, thanks so much, Perry, for giving me the opportunity to speak here. Based on the findings, what I can find, it's right up the alley. I mean, obviously, a major key point with prostate cancer always is sexual health, right? And that hits it right on the head there, especially as well mental health support. And I mean, you're seeing it consistently. I mean, traditionally, prostate cancer is assumed to be a 50 plus disease, right? That's really when you might start to see it. But as time has gone on, we're seeing more and more that younger people are being diagnosed with prostate cancer. And specifically, the really challenging part is that oftentimes when it is this early onset, oftentimes it is metastatic or it's castrate resistant or there's many other burdens that are faced with it. So I think absolutely the findings match it. I do realize with this, there wasn't a ton of information on prostate cancer on the end of it. But I mean, in my opinion, I mean, the cancer needs are pretty broad as far as things go, and it translates quite well. And it's what we're seeing firsthand, especially in our context, through our support groups, through different meetings, and everywhere that we've encountered this. I think it's, you hit the hammer or you hit the nail on the head, right? That's the best way to put it.
Thank you, Austin. It sounds like there's growing early onset cases across tumor groups, and a lot of the needs that we're seeing are disease agnostic, so to speak, right? Like that cross a lot
Well,
of the.
absolutely, right? It's needs that translate to younger people, right? These are the concerns of younger people that are more illustrated and more elevated now in the context of the disease. And like I said, it does really, it's agnostic to it. It translates across the board because of the fact that these are unique needs to these groups. So absolutely, I think it's spot on.
Are there any specific needs to the prostate cancer population that you think are important for us to consider in this conversation?
Overall, I think the biggest one to consider really is the burden of the disease itself, because it really, for men or anybody with a prostate for that matter, it creates a lot of burden, especially in the sexual health context. And oftentimes it's a conversation that doesn't get discussed, right? Because the whole treatment regimen that you're going on for prostate cancer is effectively, in many ways, eliminating that ability to do it. So in an early onset case, this is a major issue, especially in the situation of sexual health. So understanding that for me is the biggest ticket there, that or the mental health, right? Because the treatment regimen does have a lot of side effects to it. You have a lot of burden, you have a lot of quality of life loss overall. It's something that we see across the board with our support groups. And it's something that we really focus on because of the fact that, you see that things like suicide consistently go up with rates of prostate cancer, right? Because of the fact that it is such a significant burden. So those really are the biggest ones, in my opinion, that really tack on.
That's a really good point. And so every disease group is going to have sort of a different balance of needs, but a lot of them cross over universally. Thank you. Michelle, can we come over to you to get a bit of an understanding of what you're seeing in the early onset lung cancer setting, in terms of what young folks are expressing with unmet needs and how that relates to the survey findings?
Absolutely. Thank you, Perry, for having me here today. Yes, we absolutely see the same findings as your survey indicated. One of the main problems that young early onset lung cancer patients have is the stigma of lung cancer. They overwhelmingly these patients don't smoke. And even if they did, their smoking has nothing to do with their onset of lung cancer. They're also far more likely to have a targeted medication associated with their treatment. So that produces sort of a longer survivorship issue, because people on targeted therapy can, live for many years. So their survivorship needs, going back to work, these are things that for most of the population, they're retired. They're not looking at going back to work. And they also feel very isolated because of the lower numbers. They don't feel that they have kinship with other lung cancer survivors. So the need to have this kind of clinic where they could meet others that are dealing with cancer early onset would be vital for forming a support network.
Thank you, Michelle. Sounds like some similar but also unique needs in the lung cancer population. And we'll come back to this question towards the end, but I think some similar themes throughout. Brenda, wondering if you could comment on the unmet needs in your population and how that relates to the CRAN survey findings.
Good morning, and thank you to CCRAN for hosting a fabulous symposium on a much needed topic about early age onset cancers and for inviting me to be part of it. There is limited access to specialized young adult cancer clinics, and I'm based out of Red Deer, Alberta. And so there are 2 AYA nurse navigators at the leading cancer centers in Alberta. So one at the Cross in Edmonton and the other at the Arthur Child in Calgary. And so the patients are given that number. I'm not sure if it's right away though. And then they have access to these nurse navigators, and then they have virtual clinics if they are not living in Calgary or Edmonton. So the unmet needs that are most prominent for our cancers include the psychosocial support, as indicated by the survey, as the patients cope with the devastating diagnosis of such an aggressive cancer, finding others that have the same cancer because it's a rare cancer, and so they know they're not alone. That's a big one. Financial support. We don't have, for our cancer, there's not a lot of targeted therapies, and so once the initial therapy is finished or fails, then they're scrambling to find another targeted therapy. And so often they have to either go across the country or to the States or to Europe for a second kind of targeted therapy. That's if they've had their biomarker testing done, which is another comment, right? So that's a big worry. And then because they're, of course, in that age group, they don't really have a lot of funds that they've saved up, or they may not have that long-term disability at work. They worry about their family and kids and finding help to care for them as they navigate the disease. And then as the disease progresses, pain management becomes more crucial. The younger age women do worry about being able to have a child, like that's important as well. But as they get older, like the older 35 on, if they've had children already, it's not as important. I do believe that CRAN's findings do align with what we're told. The patients need to know more about the available supportive services. They are so overwhelmed initially that it's essential to remind them of the services repeatedly. So you can't just tell them once, you need to gently remind them each time. The mental health, nutrition, and fertility are questions asked of these patients and caregivers. Mental health support or counseling is significant because it's usually diagnosed with stages 3 or 4. It's usually metastasized. So we have cholangiocarcinoma and hepatocellular carcinoma. Cholangiocarcinoma has about 800 patients a year that are diagnosed. Hepatocellular maybe 3,500. So they're fairly rare. Most of them do have questions about nutrition, so support is helpful, whether it's access to a dietitian, a cookbook, or even a nutrition book or webinars. And another service of huge concern is the financial support, which I also mentioned. Many of the patients have to take time off work. They may or may not have the sick time. The family members may have to take time off work, especially if the family members are not available. So because we're such a large country and because we have a lot of immigrants, they sometimes don't have family members that can actually come and help support them while they're going for their treatments. And so they scramble to find people that may help look after their children. We also don't have a lot of medications that have reimbursement recommendations. So as I mentioned before, once they finish that first therapy, the standard of care therapy, then they might be scrambling to try and find a second targeted therapy or a targeted therapy period. And cholangiocarcinoma has a number of mutations, and hepatocellular has more treatments available than even 5 years ago. And I think in time, cholangiocarcinoma will have more treatments available. I think the biomarker testing is very important, which was mentioned yesterday. It helps helps direct where they're going to go for their targeted therapies. And the gaps within the specialized clinics, there's a fear of relapse if they've had surgery, and the NED, or no evidence of disease, is a valid point. We have a very high recurrence rate between 66 and 75% after surgery, even if there's clear margins. And so that's really a big fear for patients. And pain management is also something that we see. So connecting them to the palliative pain team is very important. And survivorship care is something we want to strive towards. And we have our 5-year survival rate's like 10%, so we're not there yet. But even the people that have survived, we don't have a plan for them, but we do talk to them about it, and we're going to get there. We are going to get there. So thank you very much.
Thank you, Brenda. Some really important points. And I think something I'm reflecting on from yourself, Austin, and Michelle is some of these unique needs for young people within diagnosis groups that are relatively rare or that have relatively fewer young people diagnosed compared to other age groups. I was hearing across the three presenters the stigma, the loneliness, the isolation, the needing information and struggling to find it. Before we move on, just curious if, any of those three folks want to comment on any of those pieces.
I can comment. So I think once the patients do find our charity and we hook them up with a mentor or our patient group support groups, I think it really does help them. And you can see through time, talking to them over time, that almost not real, it's relaxing the right word to say, but sort of more of a calmness coming over them because there's other people there that understand what they're going through. It's not exactly the same, but they understand. And so I think that really makes a difference.
Community is the antidote to isolation oftentimes, right?
Yeah, to further Brenda's point. Oh, sorry, Michelle, go ahead.
No, go ahead. I was about to say sort of the same thing to further Brenda's point. Yeah, that building of community is so important to have knowledge that others are out there dealing with the same illness. We often refer people to Young Adult Cancer Canada, and I think they've had some active lung cancer members in the past for that sense of community.
And
Yeah,
Austin, last word, and then we'll move on.
Yeah, it's all good. I'm honestly, it's the same situation in Prostate Cancer Foundation Canada. Obviously, we run support groups, and that's a main tenet of what we've always done. And you do notice it, and it's interesting where a lot of times it'll be someone who is early onset, who is paired up with someone who is in the more traditional camp, right? And has crossed this bridge and has dealt with a lot of this stuff. And there really is that mentoring aspect and that easing the burden and understanding, okay, this is what to expect. This is what the medication feels like. And because and I use this analogy a lot. When you get a cancer diagnosis, you get a bunch of things thrown at you, and then it's okay. You got to pick up the pieces and make a decision right now, right? There isn't really a lot of time because oftentimes it is time sensitive. So these people get this incredible load, but then when they can go to a support group or they can meet with people or pair up one-on-one and have that sense of community, it eases it because all of a sudden the informational overload goes from this to this, right? And then they can go and they can talk and really assess what's going on in the situation from a different perspective rather than being all alone. And oftentimes it doesn't help that with these cancer diagnoses, especially in the younger group, you isolate, right? You don't know what to do. You take a step back, you're away from everyone around you. So it's really about driving people into that community and making them know that they're in the fight with other people and not on their own. So
thank you. So having that space for young people to really be seen and heard for their unique needs is so vitally important. Thank you. So now on to the second question here. Do you foresee that introducing models of care tailored to AYA and early onset patients would help address these unmet needs? What barriers do we need to be thinking about to scale this care model, and how can these be addressed? So to start us off, I'm going to ask Maureen to share a little bit of her thoughts.
Certainly, thank you. So I mean, absolutely, I think, you know, from Pancreatic Cancer Canada, we see a strong case for introducing these kinds of models. We know there are numerous ways that age and life stage are impacting and are really central to the experience of somebody going through a cancer diagnosis, whether that be, you know, entering a different life stage than what is traditional to this kind of oncology pathway. They're, as you know, as people have mentioned, they're working full time, they're potentially building families, they're raising young children, maybe they're caring for their own parents or elderly loved ones. They're navigating major life transitions, their financial and emotional pressures look different. You know, and then of course the mental health aspect as well. We know that all of those things have different impacts and burdens and for folks at that life stage. And so for our perspective, you know, we're really talking about recognizing that journey and how it shapes those unique set of circumstances, and knowing that the medical system isn't always really set up to hold that. And so a specialized model of care can make sure that those needs aren't really like left to chance, or for people to kind of stumble across us if they've asked the right questions. It creates that more intentional pathway to find supportive care and mental health supports and nutrition services and all the things that people need when they're experiencing a cancer diagnosis in sort of that AYA or early onset space. We've seen it in our support programs. You know, pancreatic cancer is already a bit of a niche cancer. It is considered more rare. You know, about 6,000 people in Canada are diagnosed a year, and there's smaller numbers for the early onset patients. But of course, we're seeing those numbers shift as well. And so they don't always see themselves reflected in the cancer experience that is typical for our bracket. And that they might be the youngest person in the waiting room, in the support group. And so they're looking for folks who are understanding what they're going through. We've actually created an early onset under 55 support group specifically for this reason. It is open to everyone, but the intention was built out of seeing folks in that early onset category getting pancreatic cancer. And so, you know, that model of care really needs to be built with folks in mind, so they're not experiencing that sense of otherness. And specific for pancreatic cancer, I think because the survival rate is so low, when you're getting that kind of diagnosis as a young person or a younger person, your life is still, it feels like your life is still in front of you. You're looking at your children, you're looking at your partner, and all of a sudden everything is upside down. And so they become really strong advocates for themselves. They're driving their own support needs, which they shouldn't have to do, right? They shouldn't have to beg for access to these things that should be available to them. And so, you know, we really would love to shift that conversation.
Thank you, Maureen. I think something we're hearing, a theme in this session so far, is that because we're not addressing these needs in the healthcare setting, community groups and supports have sort of popped up to meet that gap. And I think we need to be thinking about an and model, not an or model. Like we need specialized services and supports within the healthcare system to then be supplemented by the work that community groups are doing that is so vital. Teresa, going to come over to you for your thoughts.
Hi there. Thank you for having me here. I actually just wanted to build a little bit on what Maureen was saying and what you just said, Perry, about the supportive aspect of it. So our group specifically was started by myself and Katie, and we were both young adults. I mean, Katie was 21 when she was diagnosed, and I was 45 with my second diagnosis. And so we really felt that lack of actually a systemic barrier. There was absolutely nothing out there for people diagnosed with stomach cancer, which again is one of those orphan cancers that, you know, not much awareness, not much funding, and really not much support. The other thing that, you know, so I totally agree that yes, we need to do something about this. And there is definitely a lack of education with respect to like the healthcare professionals. They need to be educated on what these needs are for these younger patients. And honestly, we know it. There's a lack of a national program. I was just doing some, you know, outside research about this, and in Canada, there's only 10 identified AYA, EAOC clinics, and they're focused mainly in BC, Alberta, Manitoba, Ontario, and Quebec. And so, absolutely, these are this age group, this population. You know, there's so many needs. I mean, I could speak here for like hours on it, but a few of the things that I would say just from our perspective as well, you know, from our patient community is delayed diagnosis, which in itself is with stomach cancer very, very typical because, you know, symptoms don't appear until it's very late, let alone in an earlier, you know, a younger patient who basically are being pushed aside or ignored, or, you know, in a, you know, real life case, Katie was basically told that she was trying to get out of her university exams because she kept collapsing, right? And so there was this, you know, this lack of understanding of the symptoms that that should be red flagged in younger patients. I think the other thing definitely with, you know, within our group, and I think just across the board, is the psychosocial and emotional distress. And I say that because within our community, there is a complete overhaul of your life. Your life gets turned upside down, especially for those that get a total gastrectomy, because life is food, food is life. And so people go through this physical transformative period, or it's one of the side effects. I mean, personally, I lost about close to 100 pounds. And so your entire being changes, and your entire, the way that people look at themselves and see themselves, and that is rarely addressed at the clinical side. And so I think as supportive, you know, supportive groups, I think that's where we can come together. And, you know, whether we create, you know, as I think it was Austin that said, or Maureen, that we create a support group that is specifically a subset of very young people. And, you know, in stomach cancer, we've had people as young as 11 diagnosed, and 15. And so how do you deal with that? And so I do think that that is one of the things that we as organizations can maybe take on and work together and kind of maybe form some kind of, you know, high level understanding of it, and then roll it out to our individual communities.
These are really interesting and important points, Teresa. And something I'm hearing is that in some of these diagnostic groups, the impacts are so profound, but the number of patients would be hard to justify like an individual clinic for just early onset stomach cancer in one specific center. But I think a theme that we're hearing is that so many of the needs are similar across diagnoses. Not all of them, but there are similar needs, right? And perhaps that can be a place to leverage medical expertise to deliver to young people across diagnoses. Thank you. I'm going to come over to you, Bakun, to share your perspectives from the breast cancer community.
Thank you, Perry, and thank you, CCRAN, for having the Canadian breast cancer as part of this conversation. So looking specifically at the breast cancer community, so about 17% of Canadian women diagnosed with breast cancer are under the age of 49. And breast cancer is also the most commonly diagnosed cancer in women aged 20 to 49. So being diagnosed with cancer that is predominantly diagnosed in older women comes with unique challenges and needs, many of which are psychosocial. And this can also include challenges and needs around being both a caregiver and care receiver, navigating intimate relationships, impacts on self-image and femininity, and of course, along with those that were highlighted in the survey, especially given that the survey predominantly had a lot of breast cancer patients as part of the population. So AYA and EAOC models of care, whether through tailored resources, programs at existing centers, or dedicated centers, have the ability to address some of these needs. This is because they take into account how age impacts a person's experience of their cancer diagnosis. So, for example, we hear from young women diagnosed with breast cancer about how isolating it is to face cancer at such a young age. And of course, we've heard that again through other panel members, and how oftentimes they're the youngest person in the treatment room. So having a dedicated program at an existing clinic or a dedicated clinic itself could address things like this. So this can be done, whether it's through formalized peer support and counseling, which would address this need directly. But even simply seeing other young cancer patients can make someone with breast cancer at a young age feel less lonely. Some other needs that AYA and EAOC models of care can address are timely fertility counseling, age-appropriate care and treatment, especially when you're diagnosed with a breast cancer at such a young age. You now start looking into, precision oncology, genetic testing, and things like that to kind of understand why the diagnosis happened at such a young age. And then, of course, tailored mental health services and practical support, such as financial support, childcare, and more. So when we're looking at the barriers, and this is something that has been highlighted and Perry, you named specifically, there are a number of barriers that need to be addressed to be able to scale AYA and EAOC models of care. But I'll just focus on two. So that's population and geography, and then the specific needs of the AYA and EAOC community. So the latest statistics from Canadian Cancer Society projects that Ontario, Quebec, BC, and Alberta have the top 4 highest cases of breast cancer across Canada. Ontario, which is the highest, is projected to have over 12,000 cases, and then Alberta, the 4th highest, is projected to have over 3,000 cases. So as we see, this is a large gap between the two. And so it means that with 17% of cancer cases occurring in those between 20 and 49 years old, we can infer that the number of cases of breast cancer among AYA and EAOC populations in each province and territory would be very low. So this population and the geographical spread poses a barrier to scaling AYA and EAOC models. And then closely related to this is the second barrier, which is regarding the actual unmet needs of AYA and EAOC patients. So again, while some needs are, definitely unique to this age group or require a tailored approach, there are also unmet needs that are shared amongst all cancer patients, as we've heard today. And this is regardless of both their cancer type, but also regardless of their age. So things like financial support needs, living with the fear of recurrence, side effect management, and others. So this presents as a barrier to scaling because if these needs are already being addressed through standard or traditional pathways, then it might reduce the number of individuals who need or who would use AYA or EAOC dedicated supports and services, especially if these supports and services are not integrated into their general care or they're out of reach for them. So this might be the case, for example, if you have an AYA patient that has to travel 10 minutes to get to a cancer center versus having to travel 45 minutes to get to a dedicated AYA or EAOC cancer center, or one that has, dedicated program. So in terms of addressing these needs, it's basically the same for both of them. They have similar, the same way and same approach to addressing them. So addressing these barriers include things like creating dedicated clinics that serve all AYA and EAOC populations. So in other words, centers that are not cancer specific. And the locations of these centers can be determined by need and population statistics. So kind of looking at where are young people more frequently diagnosed, or looking at, larger centers and selecting their location that way. They can also look into creating or expanding dedicated programs that run out of established centers. And again, depending on the population needs and the location, these programs might be specific for, young breast cancer patients. There are already a few across Ontario. So there's the PINK program at Sunnybrook, Jervinsky, Mount Sinai. So they could be specific to the cancer depending on the location and needs, or they could be tumor agnostic. And then the last way to address barriers to scaling AYA and EAOC models of care is to ensure that these resources, services, and supports that serve this population is accessible virtually. So this can look like telehealth, such as being able to access virtual mental health counseling, or being able to speak to a nurse navigator, either virtually or over the phone. It could also look like a virtual hub that houses a variety of these resources and materials and support services that are tailored to AYA populations. And then this information, if we're imagining this resource hub, it's going to obviously be large. So it could be categorized by cancer type. It could be categorized by the needs, so medical versus social, psychosocial needs versus practical needs, or it could be done by both. So, you could go under the category for just breast cancer, and then under that category, there would be another one, or, for the various cancer populations. So overall, there is a benefit to having AYA and EAOC models of care. And it's just important to ensure that implementing this approach addresses the needs that it seeks to address without creating new barriers to their actual use and utilization. Thank you.
Really important points, Bakun. We're hearing these challenges, right, in these AYA and early onset populations. And I think you have some really interesting ideas with how we can address that with some specialized types of supports. Teresa and Maureen, before we move on, just curious if you had any thoughts on some of those suggestions for how we can address these models of care.
Certainly. So, I absolutely, nodding along with Bakun as she was going through many of the barriers and the ways to address things. So, with pancreatic cancer in general, those specialists are few and far between because it is a bit of a niche cancer. It's an underfunded cancer. And so, with lower numbers overall with populations within the population. So similarly, the idea of navigating or having specific clinics specific to the cancer is not necessarily something that the system has capacity for. It's already under immense pressure, right? And so I think that the idea of having an agnostic system, it makes it less difficult to navigate some of those changes and ability to implement those kinds of services and supports. I do think as well in terms of needing that clear framework or some kind of standard of care at the provincial and national level is important to implementing some of these new ideas. Having a bit of a defined expectation could make it easier for some of these centers to build forward and build towards a pathway that services each region and that age group in a more equitable way. And of course, we need investment in these kinds of things as well, right? So it doesn't necessarily mean like massive one-time funding, but targeted funding for things like patient navigators or the psychosocial clinicians, the fertility counselors. Those are things that are needed across cancers, regardless of age in many cases, right? The patient navigators and psychosocial clinicians in particular. And so that can benefit a whole population rather than just sort of focusing on the niche. And so that might be an easier sell for some from a funding perspective. And then certainly training, I think, is needed for those inside the system. Clinicians want to support their patients. We know that. But sometimes, in particular with these younger populations, they're not necessarily able to have been trained specifically on how to support those patients with niche cancers, what resources are available. So, for pancreatic cancer, we hear a lot of the times that patients do stumble across us. They didn't know that we existed. Their doctor didn't know we existed. We know that partially that's an us problem, but partially that's a system problem, right? And so we know what we need to do, but we also need the buy-in from the system. We need people to be trained to integrate our services, all of our services, inside of a care model so that folks aren't left in the dark, they aren't left isolated, and they know that they have access to these things that can help them build community and feel less alone and get questions answered. Because often they don't get enough time with their care team. And so we can be there to fill gaps for these communities. Yeah.
Yeah, those are really important points, Maureen. I really thinking along the lines of training. I know there's a Royal College certification in AYA oncology now. I don't know how many folks have gone through that system to date, but Princess Margaret also offering AYA specific trainings. We need to make sure that all clinicians are competent in delivering care to AYAs and early onset patients, because if we start developing too niche of individuals with training, then we run the risk of having even more disparities, right? Teresa, any last words before we move on to the next question?
Yes, just a really quick couple of things. First of all, I couldn't agree more with both what was just said. And, one of the things that you said that I think, Maureen, you said is that there's not enough time in the clinic, right? Just on a regular basis. And so, yes, I think there needs to be more training to understand the needs of the EAOC, that's a mouthful, population. But I also think, and I think it was someone said it earlier, that we provide kind of that supportive care, that aftercare. And the moment someone enters into a supportive group, and this is where I kind of maybe diverge a little bit, and I think we all do, perhaps in our own way, is, when they realize that there is a group there for them that is going through the exact same thing that they are. So, we haven't done this, and I know some of you may have, and I applaud what YAC does. But, we've seen such an uptake in stomach cancer patients being diagnosed really early. We are a niche population as well, but to create support groups that are actually just focused on these younger people, where not only is it the age and everything that they go through, but it's the specific details of their specific disease. And I think that that is something that we can take on, and as I said, maybe grow together. But definitely, I think more training and more training in the communication and understanding of what these young patients are going through.
Very well said. And, I think what I'm hearing also is like the importance of giving people choice, right? Whether they want to access that specialized care through the cancer system, or do they want to access that specialized knowledge and expertise through community like we need to have both. We need to be able to give people choice and agency in that. Okay, so we're going to move on to our last question now before we get to the audience Q&A. This question is first for Philomena and then for Danny. What will it take to move the needle forward towards establishing additional AYA programs or early onset clinics in Canada? Can patient groups collaborate with stakeholders to strengthen messaging and impact towards the establishment of those care models across Canada?
Thanks very much, Perry, for the question. So I could talk an hour on this topic, but I was told I was given 6 minutes. 6 minutes, right? So I have some notes that I'm going to diligently adhere to, and the hope is that I will spend only 6 minutes. So, and I'm glad to speak to the early age onset colorectal cancer patient population on this topic, who, in my opinion, have some very unique physical and psychosocial needs that require, I think, a tailored and thoughtfully delivered program that address both sets of those needs. And yeah, they do have some unique needs compared to those with other cancers, primarily due to specific functional and body image challenges associated with the origin of their cancer, like bowel or rectal dysfunction and ostomy care. The treatments that they undergo, the colorectal cancer patients undergo, especially of rectal cancer, can lead to lifelong issues with the bowel, urinary, and sexual functions. They often experience treatment-induced side effects more acutely and report worse body image and embarrassment with bowel movements compared to their older counterparts and other tumor type counterparts. And as a result, they experience greater social isolation and intimacy issues, and the need for a temporary or permanent ostomy that often presents a slew of psychological and body image challenges that are so distressing for younger individuals who are actively forming lifelong relationships. So all to say that we at CCRAN are highly supportive of establishing additional early age onset colorectal cancer clinics across Canada based on the adoption of the very successful model that was established at Sunnybrook under the leadership of Dr. Shadi Ashamala, who I believe recognized early on in his career that young colorectal cancer patients require specialized programs tailored to respond to their unique unmet needs and care gaps. So what will it take? What will it take to introduce new early age onset colorectal cancer clinics in Canada, or just early age onset cancer clinics in general, of which we are indeed very supportive? So I believe this is an effort and process that involves collaboration between many stakeholders, including, most importantly, healthcare providers, and yes, patient advocacy groups who can amplify messaging through national events such as this one that brings together dozens of experts to generate a publication to serve as an advocacy tool. So first off, identifying a clinical champion to lead the establishment of a program or clinic often serves as a really great start for its success, because the champion can oversee the development of the program's objectives and mission, as well as oversee sustainable funding, which is very much required, as you all know, often by way of philanthropic interests fundraising, and grant applications. That's first and foremost. Secondly, ensuring that the cancer center or the institution and its foundation are on board can certainly go a long way to lending support and assistance for the program's success. And by the way, this is assuming that the program will be introduced in a cancer center versus going the stand-alone route. And I think it's probably in the best interest to go or to introduce a program or a clinic in a cancer center or a center of excellence, because you can tap into already existing resources. Thirdly, in addition to a clinical champion, a dedicated program manager needs to be included and is core to the successful implementation and monitoring of the program or clinic. I believe this can help with outreach to cancer specialists, multidisciplinary teams, as well as primary care teams, and prioritizing rapid diagnosis, as we all know that early detection is key. And patient navigation support, it absolutely has to become a part of the program. Fourthly, based on the findings of CRAN's pan-tumor patient survey, there has to be a plan for dedicated support services that address fertility, intimacy, sexual health, mental health, nutrition, financial navigation, and survivorship for these young patients, as these are the significant unmet needs that patients face. There's definitely so much more involved with respect to needs assessment and research, developing a comprehensive proposal, implementation, and operations. But I kind of figured what I've addressed is critically important in the initial part of the planning phase. I know there was a publication that was released earlier on this year in The Oncologist, supplying a blueprint for creating an early onset colorectal cancer program based on the clinical experiences of 6 U.S. cancer centers and 1 Canadian center that essentially outlines a 10-step guideline for developing an early age onset colorectal cancer program. And that can certainly help to inform efforts moving forward. And I think it's not just applicable for colorectal cancer. I think it can apply to other tumor types as well, to develop maybe a pan-tumor center or clinic or program. And then, Perry, to answer the second part of your question, collaborating with patient advocacy groups who are leading national dialogues on the creation of additional early age onset cancer clinics and IA programs. They can be so helpful because they can share resources and leverage expertise. Look at what we're all doing here today. They are in a position to promote awareness and education regarding not only the disturbing rising cancer rates in young adults in Canada, but they can promote some of the efforts that can be undertaken to help address and reverse those disturbing trends. And more importantly, I think they can support the younger cancer patients and caregivers undergoing the difficult journeys once patients learn these support systems are available. Like, look at what Teresa and Maureen were saying, and we've got an early age onset colorectal cancer support group available every month as well. Hosting events such as this one can shine a light on the need for establishing additional IA programs and early age onset cancer clinics in Canada by assembling experts and amplifying the patient and clinician voice. Patient groups in general, they stand ready to assist with the creation, the establishment of additional programs and clinics, because it is in the best interests of younger patients across Canada. By following a really structured and tailored approach that incorporates input from all relevant stakeholders, including patient advocacy groups, new early age onset cancer clinics, and IA programs can be successfully integrated into the Canadian healthcare system to address the rising trend of early age onset cancers.
Beautifully put, Philomena. I think what you're saying with collaboration is so, so vital. We can't do it alone. We have to do it together. And what more of a beautiful example, could we have than this panel here with representatives across various patient groups. And last but not least, Danny, thank you for so patiently waiting. I'm so curious to hear your thoughts as someone who brings both lived experience and patient advocacy.
Thank you so much, Perry, and thank you to all of these wonderful panelists and organizers and the audience for engaging in this topic today. It's very hard to follow Philomena, but I'm going to do my best to try. So again, my name is Danny. I use she, her pronouns, and today I'm speaking from my lens of lived experience with an early onset colorectal cancer, somebody that lives with Lynch syndrome, as well as my role as an oncology social worker and manager of programs at Young Adult Cancer Canada. We're a disease agnostic organization that works closely with those who have received a cancer diagnosis under the age of 40 through peer support programming. I also work with our friends at Gildas Club Toronto, just to shout them out as well. I think that moving the needle on establishing AYA and early onset cancer programming within Canada is going to require a few different things. I'm going to summarize in roughly 4 different points, but there's overlap for sure within these points. And as a caveat, I think because my professional realm is very disease agnostic, I did develop these points imagining AYA and early onset clinics taking a similar approach to care. I think maybe that's in part because those with rare cancers are a population I just take a particular interest in as a social worker that's aware of resource scarcity. So first, I just want to center on patient leadership. Young adults are the experts in their lived experience, and they identify gaps in care that clinical data doesn't always capture. And when you put patients at the table from the beginning, you're going to get programs that are more relevant, more accessible, and more sustainable. This cannot be a consult and depart model. This population evolves quickly. My needs and values as a millennial are not the same as somebody from Gen Z or Gen Alpha. Each generation we see has an incredible growth of diversity and intersectional experiences. We need strong program foundations that can be renovated regularly, programs that grow with the generations that they serve. Secondly, we need strong partnerships and collaboration between these clinics, organizations, and community groups. There's already excellent work happening within Canada. In particular, I'm looking at Princess Margaret or Cancer Care Manitoba, programs with evidence of real impact. We do not need to reinvent the wheel. We need to learn from what already works. I think it was Maureen earlier that mentioned creating these intentional pathways, and I really love that idea. At YAC, we get to serve the folks that find us, and we know that we could be serving so many more folks that would benefit from our interventions, but not everybody gets to us. Not everybody gets that far. We also really, I think, need to be honest about system capacity. So at YAC, we have historically sometimes seen professional healthcare providers start an AYA support group, for example, and the group disappears because that staff person takes on a new role or participation isn't sustained. And I think it's important to consider growing some of these programs and supports with external partners. For example, virtual care has been super important to this population. It's really expanded and exploded things. This way, the funding, staffing, the participation, it's not just resting on one person, one clinic. Collaboration is also going to help prevent duplication and increase reach. We're able to do programs at Young Adult Cancer Canada, in particular for folks with advanced and metastatic disease that I know would not necessarily be sustainable in a single cancer center. But we're able to provide a really wonderful, unique, and I think valuable service to folks because we have the whole country of perspectives to bring into a room. Third, integrated research and shared data are really essential. When programs can demonstrate their impact, whether it's quality of life improvements, better survivorship outcomes, system inefficiencies, what have you, it's going to become easier to secure funding and justify expansion. There are clinics in Canada that already have strong data, and we should be leveraging that. And when possible, let's share findings with community nonprofits who do not always have the same access of availability to this academic resource, right? Like there's many barriers to getting a hold of this information. So I want to in particular just shout out CCRAN for all of the efforts it does within this space, both in leading research and in doing really incredible knowledge translation work like what's happening here. And then finally, to the question about whether patient groups can collaborate with stakeholders to strengthen this messaging, absolutely. So patient groups are really uniquely positioned to unify this message, articulate the urgency, and ground the conversation in lived experience. As somebody who's worked both inside and outside of hospitals, I promise you that we are having different conversations about what happens inside the health system at a community level. We can bring new and diverse perspectives. When patients, clinicians, researchers, and community organizations present a coordinated vision, we can stop advocating for these isolated pockets of excellence and start advocating for a national standard of quality care. And for real sustainability, we also need to envision a system where there are some needs that are transitioned out of the hospital and into the community. Those of us diagnosed young are going to have complex needs across our lifespan. I know that's true for myself. But the hospital cannot and should not be all things to all people. That does not serve the system or the survivors. So I think strong community partnerships are, again, a part of this solution. So to me, moving the needle looks like a lot of things, but coordinated patient-led advocacy, shared learning across these provinces, and a commitment to building on what already works rather than starting from scratch. I think that is some of the ways that we can approach building a model of care that's going to meet these needs for folks across the country. And thank you.
Wow, Danny, I think you just summed up this session so perfectly in the last 5 minutes. So thank you for that. And we're right on time, which means we have time for lots of the Q&As that are coming in. I've got lots of questions here, and we're going to move through them. Because we have such a big roundtable, I'm wondering, panelists, if you want to raise your hand through the React feature, and I can sort of come to you if you'd like to share on some of these points.
Sure.
So first question, really important. For tumor types with larger early onset populations, like colorectal cancer, are there benefits to having tumor-specific early onset clinics? These tumor types have specific needs, for example, ostomies that might not be well addressed through tumor-agnostic clinics. And I would add on to that too, like in the breast population, huge body image concerns, mastectomies. In the CNS population, lots of cognitive impairment, fatigue. So there are certain pockets that do have unique needs and curious. Yes, Philomena, feel free to start us off.
So you have to know that I'm very much in favor of, if it's possible, to establish early age onset colorectal cancer clinics, only because this population does have some very unique needs associated with bowel dysfunction, with ostomy care. And oftentimes when they are diagnosed with, let's say, rectal cancer, because colon cancer has some different, I would say, challenges associated with its management, but when they are diagnosed with rectal cancer, the radiation-induced toxicities bring on a slew of challenges that, let's say, require some handling, some significant expertise, both from a psychosocial perspective as well as, I would say, clinical perspective. And as a result, a center that is well equipped with a young adult colorectal cancer clinic that currently exists at Sunnybrook, I think would be so very helpful. The other thing is, I've known patients who have undergone a pelvic exenteration where not only do they end up with one stoma, but they end up with 2 stomas. Good grief, that is a journey that just requires kit glove handling. And so I can most certainly understand the significant benefits of introducing a tumor-specific clinic program for colorectal cancer patients who just undergo some very specific, unique challenges and barriers and care gaps if they're not, let's say, exposed to some supportive care services that are uniquely introduced when a clinic goes up in a center of excellence, in let's say a cancer center, because I have seen firsthand the benefits, the wonderful benefits that have come about over time from, let's say, Sunnybrook's Young Adult Colorectal Cancer Clinic. Just thought I would
I mean,
explain.
it's world class, truly.
It
And I
really
think
is.
in
It
a
really
perfect
is.
world, I would love to see that absolutely everywhere. And from a capacity building standpoint, I do also wonder if there's opportunity to build up expertise in supportive care staff, like in ostomy nurses, like in psychosocial care
Wow.
providers, right? That could sort of extend the expertise farther than one standalone clinic could. But yes, I completely agree.
Thank you.
Danny, go ahead.
Thank you. I often think about the palliative care model and how it could be applied to like the AYA population or the EAOC population. So having this clinic that works collaboratively with other parts of the healthcare system, and so like something I could imagine working really well is like this AYA EOAC clinic that has these specialized branches or education within them. So like maybe it is an AYA program that has a specific collaboration with the hospital's colorectal care group to meet some of these like specific needs that like, as you're talking about them, Philomena, I'm like, oh boy, I forgot about all these fun things that I've journeyed through. And I have seen these collaborations. In particular, I'm thinking about some of the efforts that Princess Margaret has done with their stem cell transplant population or their heme populations, because we know that there are young adults that are regularly diagnosed with these types of cancer that have this type of really intensive care. And they're still benefiting from the wider AYA supports that are relevant to all or most of the diseases that have their own kind of needs here. But then how do we speak to some of these like specific moments that happen based off of, let's say, a stem cell transplant or what have you?
Really important points. Any other thoughts from the panelists? Okay, we've got lots of questions, so don't we're moving on. I think Danny, you sort of answered the next question around, is there a model of care for younger adults that exists that could serve as an example of best practices and can be expanded across Canada? I wonder if folks from any of the other tumor groups or representatives have any thoughts about other models that they've seen that works well. Yeah, Austin.
Well, I think a big one, and I mean, this is reflective of the group that we're in here, is really the function of the support group and having that ability to discuss, right? And it's a neglected aspect of care in that regard, right? A lot of times it's not put to the forefront, it's not discussed as much as it should be. But I mean, clearly from this panel, you can see it, right? Everyone in here has some reflection of the support group and the power of that and being able to have that conversation. So in my opinion, being able to implement that on a larger scale is really what's going to be the big force of change, right? Obviously, our healthcare is at a good standard. We need to continue to elevate it, but it's at a good level, I say, across the board, roughly speaking. But adding that extra help, a lot of that comes from your peers, right? A lot of what we've talked about, the mental health support, those difficult conversations, as Philomena said, treating it with serious kid gloves, right? That's something that comes from having a discussion with someone who has lived experience or just being able to share. And so really, for me, putting the support groups on the forefront and really having that as an option for patients, especially in the context of an early onset group and being able to talk with their peers and discuss these things, I think that elevates it to a different level, right? And really being able to give them that opportunity to hear what it's like and to know that they're not alone and really sharing that and being able to have those difficult conversations without the fear of being judged. Or, and I forget who said it, but trying to talk to your oncologist at this day and age, clinic times are out of control, right? Let's face the reality there. When you try and talk with your doctor, it's a quick consultation and okay, I've got to move on because your doctor usually has 40 or 50 other patients they've got to see. So being able to have a group to, share these questions, ask difficult things, talk about medication, talk about what does it feel like on this day, I think it changes the game. So that's really where I stand on it.
Really important. And can we look at models to really integrate community services with the clinic so it's not that patients happen chance come across CRAN or EAOC or Prostate Cancer Canada, but that it's just an integrated, seamless sort of transition. Yeah, Teresa.
So I couldn't agree more, Austin. Honestly, I think, and it's one of the things that we have tried to do right from the get-go, from when we started, was to bring, the advocacy group and the patients to the forefront. Whether it's through, I mean, the hallmark of our foundation is support, where people can, you come in and you talk about topics that you would never even think about talking to with family, and sometimes even with your medical health caregivers. These are people that understand the not so fun aspects, which are many, of the specific cancer, whether it's colorectal, prostate, stomach, breast, whatever. I mean, there are such diverse needs. And I also think, what you said, Austin, about, with the support groups, absolutely, we should be involved right at the beginning, like integrated into formalized healthcare models, right? Integrated into research. So one of the things that we really try to do is get involved with research in helping to be patient advocates, patient partners, help to design what the research is, so it actually means something to the patients and there is a direct impact versus, some, and I get it, these 5-6 year programs, but research programs, and some of them are that, but some of them that have a direct impact, like nutrition or something like that. And I think without the patient perspective, the patient advocacy group perspective, who, kind of, I know with us, we've lived it, and so we talk about it. But I couldn't agree more. I think without that element, you're never going to get to the level that I think the AYA group needs, or any cancer patient needs.
Excellent. I agree. Bakun.
Yeah, so just specifically in terms of like if there are any models of care that exist. So for breast cancer, I know there's the PINK program for young women with breast cancer. That was started at Sunnybrook, and then it's expanded to Mount Sinai and Jervinsky Center. I don't know like the specific details of it or if it's expanded elsewhere, but just to say that there are certain models that already do exist, and they've been, these are programs that are integrated into established centers. So it's definitely something that if we were to look at, expanding it rather than starting something new, it can be something that, you connect with this program and just have that exact program, in a different center. And I think something that is helpful with that, I think Maureen mentioned it earlier, is that aspect of standards. So if there's a program that already exists and has been expanded, and we can see that, it is meeting the needs of the AYA population, rather than creating something new in, say Alberta, you just kind of follow something that already exists. And that ensures that, if you're diagnosed with breast cancer at 35 in BC or in Ontario, that you're getting the same access to care, the same approaches. So of course it's going to be updated based on like the specific location, but it still has that same standard. You're still making sure that there's equitable care across the board.
Very well put. We could keep going for the whole day, but I think with that, we will end the session. Thank you so much to our phenomenal panelists who bring such a wealth of expertise, lived experience, professional experience. We have a lot of work to do in terms of making more equitable, specialized, developmentally appropriate AYA and early onset care in Canada, but we also have so much momentum, and it is so exciting to see. So thank you all for being here, and hopefully at the conference next year, we'll have even more insights to share. So with that, I will close the session.
Thank you.
Thank you, Perry. You did a
Thank
fantastic job of moderating a very big panel discussion. And what a wealth of expertise amongst these panelists. You guys all have such thoughtful insights, and we are truly grateful for the opportunity to collaborate and look forward to, continuing with this momentum and continuing to work together to better the outcomes for early age onset cancer patients across tumor types and across our country. So with that, we'll head into our first break of the day. For our viewers, please take this opportunity to move and nourish your bodies. We will be sharing featured industry, patient, and clinician videos throughout the break. And then we are back at 12:45 Eastern Time with a panel discussion exploring intimacy, reproduction, and fertility in early age onset cancer patients. We'll see you then.